All right, hi everybody. Welcome to CADIO's webinar series. Thanks so much for being here. We are so happy to have our collaborator, Dr. David Vanness, here today. Dave Vanness is a professor in the College of Health and Human Development at the Pennsylvania State University in University Park, where he directs the doctoral program in health policy and administration. He received his PhD in economics from the University of Wisconsin-Madison in 2000 and has served on the faculty of the Mayo Clinic in Rochester, Minnesota, and the University of Wisconsin School of Medicine and Public Health. He taught short courses in Bayesian statistics for the International Society of Pharmacoeconomics and Outcomes Research, ISPOR, for over 15 years and was the founding chair of ISPOR's Statistical Methods in Health Economics and Outcomes Research Special Interest Group. Dr. Vanness's research uses computational methods to translate statistical evidence into improved decision-making in the areas of health technology assessment, healthcare policy evaluation, and intervention optimization. So Dr. Vanness, thank you again for being here.
Wow, thank you. Jillian, it's an honor to be able to present to CADIO. An honor to be introduced by graduate student and a star. Linda and I had the great fortune of co-mentoring Jillian at Penn State in her PhD, where I was very fortunate to attend a brown bag seminar one day that was being presented by Jillian, and Linda was present there, and Kate Guastafaro was there, and I began what turned out to be an unexpected and wonderful career move to learn about intervention science and intervention optimization using MOST. And so I'll be talking to you today about some work that we have been doing collaboratively to bring tools of Bayesian decision science and health economics and outcomes research and embed them into MOST's processes, particularly in the optimization phase, using decision analysis for intervention value efficiency. And my goal today is to try to recap a little bit. You may have seen Jillian present on this topic. I'll recap a little bit about what DAIVE is and what it tries to do, but then contrast it with the more traditional health economics approach of cost effectiveness analysis as it has been used largely within the field of health technology assessment. And why really we think that a different tool, but related tool, is useful in the optimization phase of MOST to help intervention scientists and other interested parties make decisions about which interventions should be advanced for further consideration. So without further ado, oh, it's not letting me advance. Let me try this again. There we go. People who should obviously be well known to you all, Jillian and Linda have been partners in this endeavor, and much of this work is related to work that Jillian did as part of her dissertation. I want to thank many others, some of you who may actually be here, Doctors Cleland, Guads, Guastafaro, Nam, Shani, and Wilton, who either through application of DAIVE to the Heart-to-Heart 2 study or through other sort of stimulating intellectual content have helped me formulate some of my argument for why this approach is useful and how it differs from traditional approaches to cost effectiveness. So a little bit of context. So decision analysis for intervention value efficiency, or DAIVE, was introduced in a very recent publication in Health Psychology. It's still an online-only format, I believe. But it's a framework for how to make decisions about which combination of components or which combination of factors of different components in a multi-component intervention should be considered optimized and should be advanced on for further consideration in ideally in an evaluation RCT. This particular approach helps to balance intervention performance on multiple outcomes of interest. So not just a primary endpoint, but on multiple things that our interventions tend to affect. And it balances that against the delivery cost of the intervention. And we'll talk about the difference between delivery costs and other costs a bit more in the future. But again, recognizing that our goal here is to make this kind of balancing decision, recognizing that there are often trade-offs when we make choices. Ideally, we would want to choose an intervention that does the best on all of the outcomes that we care about and is, the most affordable intervention of the ones under consideration, but it's rare that we get everything we want. The goal of DAIVE is to help us get what we need. And so you've seen probably many versions of this figure many times as well, highlighting here the two fields within the multidisciplinary endeavor of MOST that DAIVE really most directly relates to, and that is using principles of health economics to optimize and manage resources within trial, but also within the implementation phase of implementation science. And after all the work is done, we want to have an intervention that makes efficient use of the resources of society to produce desirable health outcomes. It also uses principles of decision science. The decision science is clearly related to the economic sciences, but with a more multidisciplinary background that involves designing and implementing methods for how to make difficult trade-offs with particular goals or endpoints in mind. And also another diagram I'm sure you're all familiar with, and highlighting where DAIVE lives. So the principles we're talking about here today are currently developed to help with the optimization decision, to identify the intervention that meets the optimization objective in the optimization phase, and also to give investigators a sense of whether the optimized intervention is expected to be good enough to be warranted to move on to a future evaluation phase RCT. And so that's where DAIVE currently lives. We are working on methods to expand the context of DAIVE to potentially bridge closer into the evaluation phase in a more seamless design, and where one could envision having an optimization phase trial that is done sequentially and eventually becomes an evaluation trial, and very exciting work that's currently under development, but I won't be speaking about that today. So just a teaser there. So a little brief overview. So we assume that we're starting with data from an optimization RCT, and this could be one of the many designs of optimization RCTs, but so far DAIVE has been developed primarily thinking of the factorial family of designs in mind, so full and fractional factorials, assuming that we have data after the conduct of an optimization RCT of that type. DAIVE uses Bayesian methods to estimate something that we call the posterior expected value of each outcome. And this is a common term in Bayesian decision science, where we use Bayes' rule to take the information gathered from the optimization trial and predict the outcomes that one would expect under each of the candidate combinations of intervention components that are under consideration. This approach then does what decision scientists call propagate uncertainty, to take the uncertainty in the estimated effects, the beta hats, and to translate them into overall uncertainty about each outcome under each intervention, the y hats. And so you can imagine that we have estimates of all of the effect parameters of interest from a factorial design model, where in the example of a simple 2 to the 4th factorial with interventions sort of non-creatively labeled A, B, C, and D that if they are present at their full level, receive their letter names, ranging from a minimal intervention where none of those components are at their high or on level to the full intervention treatment package where all 4 are present. We have grand mean effect, we have multiple main effects, we have two-way interactions, three-way interactions, and the full four-way interaction. All of these estimates, rather than sort of look at them individually, long tables of ANOVA output and try to weigh main effects versus interaction effects that might work in opposite directions. They are translated through a likelihood function, the function of how the observed outcomes are related to those effect parameters, into uncertainty about the overall outcomes. And in this case, I've drawn just a purely hypothetical situation where perhaps the best performing combination of interventions is not the full treatment package with all A, B, C, D components set to on, but rather one where B is left off. And in this case, choosing which intervention to set forward as the optimal based on the expected values of Y hat it is really something that is consistent with the principles of economic decision-making under uncertainty. And this traces back explicitly to work done by Carl Claxton and published in 1999, but really is a principle that goes further back to the 1950s and the very beginnings of the field of decision science. This helps us avoid making complex and possibly conflicting estimates of main and interaction effects that can be a complication in the optimization phase of most. Now, this is particularly the case if you have more than one outcome of interest, because main and interaction effects, even within a single outcome, may require careful consideration to make choices about which components to include or exclude. Once you include other outcomes that might have a completely different set of effects, it becomes even more complex. And so this approach will use a value function to help bring together the multiple outcomes into a single picture and further make that choice. So continuing with the brief overview, if we have expected Y hats for each outcome from this process, we then will use multi-criteria decision analysis, which is a field that dates back explicitly to Keeney and Rifa's work in the mid-1970s and has become a very important part of health technology assessment evaluation and evaluation of policy options in a variety of fields to help evaluate an intervention's beneficial and not so beneficial attributes given decision makers' assessment of the relative importance of those attributes. In this case, the different types of outcomes under consideration. So, for example, we will use a specific example from Heart to Heart 2, but I would imagine that many of you in your work find it difficult to choose a single primary outcome when you're designing your RCTs. What is the most important goal to shoot for as the therapeutic effect of your intervention when there could be many, and not all of them necessarily are positive? You may want to balance a beneficial effect against participant burden or a potential side effect. How you weigh the relative importance of achievements in those outcomes can be expressed using what we call a value function. And in perhaps the simplest and turns out a very robust form of value function is a weighted linear value function, where you may have to rescale those outcomes to be on a comparable scale, but then we assign decision weights to each of the outcomes and come up with a composite value function for a composite endpoint. This then is used to balance the value of those outcomes achieved against the delivery cost of each intervention using something that we are calling the value efficiency frontier. And this has been implemented in a graphical application that is meant to be used interactively with intervention scientists. It is currently using application developed in Shiny with R, and has been used successfully and is being used in a number of applications. And for further information on that, definitely feel free to contact Jillian. Many of you may already be working with Jillian on similar types of work. But to give you a sense of what the picture is, imagine that each of these dots represents the expected outcome or the set of expected outcomes that are put together and combined into an overall value weighted outcome, V of Y. and plotted against its delivery cost. Each dot represents a different unique combination of intervention components set to one of their levels of their factors. And in the case of a simple 2 to the 4 type design where you have on or off components up to 4, there are 16 of these dots representing everything from the minimal treatment where all intervention components are set to their minimum level to the full treatment package. And what I have done here is to identify the value efficiency frontier. And each point on the value efficiency frontier has a particular feature, and that is that there is no other point that is below and to the right of any one of those points. And what would it mean? Let's say, for example, we'll pick intervention CD. Hopefully you all can see my cursor moving here. Usually it works that you can see the cursor, but if not, let me know. Yes, I see a thumbs up. Thank you. So intervention CD is quite effective. It is one of our most effective interventions in delivering the combination of outcomes that are desirable, and it occurs at a relatively modest cost. There is no other treatment combination that provides better outcomes at a lower cost. Anything to the lower right of one of these points would be called a dominant point, and a dominant point is an intervention that delivers the best cost at the lowest price. And so there is no such intervention. Here, the ones on the frontier, all the thing that we can say about them is that no other intervention dominates them. So there is no intervention that delivers better outcomes than CD at lower costs. There is an intervention that delivers better outcomes, ACD, but it does so at a higher cost. And there is an intervention on the frontier that delivers a lower cost, both A and the minimal intervention, but to do so, you are trading off lesser performance in the evaluated outcomes. I've highlighted one other intervention combination. I haven't labeled it. It could be some combination of other factors here. This one is special in that this point, there is no intervention that is below and to the right of this point, but yet it's not on the frontier. And I think if you can visually and graphically see that to get it onto the frontier, you'd have to kind of deform the shape of the frontier. So it no longer has this nice kind of convexity to it. Even though there is no single intervention that is both more effective and less costly than the one highlighted in gold here, a linear combination of interventions A and CD would dominate. And what we mean by a linear combination? You could imagine coming up with a new hybrid intervention that flips a coin. And if it comes up heads with some probability around 0.5, you would get intervention A alone. And if it comes up tails, you would get intervention CD. That hybrid combination intervention, even though it's admittedly artificial, that would be both more effective and less costly than this interior point here. And so we leave those off. We call those extended dominated points. And they generally would not be considered efficient uses of resources. To be efficient, you have to be on the frontier. However, moving along the frontier tells us about your values. So in the process, you begin with the minimal intervention as the least costly and least effective intervention in this particular example. And the decision maker would be asked the question, to achieve outcomes consistent with intervention A, you have to spend cost represented by the slope from the slope of the efficiency frontier from the minimal intervention to A. Is it worth it to spend that cost to achieve outcomes A? And here, in this case, we achieve quite a large improvement over the minimal outcomes, at least as visually depicted here, for a relatively small cost. And as we move along the frontier, things always get steeper. So moving to the next intervention, which in this case is intervention consisting of components C and D set to their on or maximum level, we get better outcomes, but at a higher additional rate of cost per unit improvement of outcome. And the decision maker has to ask themselves, is it worth it to achieve that greater improvement in outcomes at a proportionately higher cost. And then finally, in moving from intervention C, D to now adding component A to its on position or to its higher level, we now get the highest level of outcomes achieved, at least as weighted by the value function. But to do so, we incurred a relatively steep increase in cost. And the word steep here is intentional. This is actually a steeper increase in the cost level to achieve a smaller improvement in outcomes. So working through this process helps the decision maker to decide which intervention should be advanced, or perhaps combination of interventions should be advanced for further consideration. One could imagine that it might be worth it to include both ACD and CD in a future, perhaps 3-arm evaluation RCT, where the final decision about which is optimal after the evaluation RCT might depend on the resources available to whomever is going to ultimately implement this intervention in the real world. We'll come back to these concepts of final adoption costs after a while. So an example from Heart to Heart 2, again, I'll move through this relatively quickly because I believe many of you have seen this before, but just to give it some concreteness, in Heart to Heart 2, the intervention consisted of multiple components to try to improve adherence to antiretroviral therapy and reduce viral loads. But viral load was not the only goal of the intervention. We'll see a little bit more about that. Here, the components, there were 5 of them that could be set at either an on-off level, such as motivational interviewing sessions, focus support groups, peer mentorship, and pre-adherence skill building, and a 5th component that had 2 factors that were not on-off, but rather a longer version of the navigation component and a shorter version of the navigation component. Each of these having different costs and each contributing differently to desirable outcomes. From a figure directly from the paper shows a picture of the value frontier before we have actually drawn that frontier. And as you can see, each particular point on this figure has been plotted where the value function considers VL, the single outcome VL in this case is viral load. So if we were only concerned with viral load and wanted to look at the intervention combination of components that achieved the best improvement in viral load, the largest reduction in expected terms, it was the combination of motivational interviewing, the skill building, the peer mentoring, and the longer version of navigation. That achieved the highest overall reduction in viral load. And it did so at a relatively high, but not the highest cost. Now the question is that our optimized intervention? How would we decide? And what if we didn't only care about viral load, but we cared about other outcomes as well? So from figure 3 in this paper, we now have identified the value efficiency frontiers for 4 different scenarios. In the upper left scenario, that is the value efficiency frontier for viral load alone. In the upper right, we now look at a different outcome, overall health-related quality of life, which was measured by improvements in the Euroqual EQ5D, if I recall correctly, or maybe, I'm sorry, maybe it was the SF6D. I apologize for that. But it was a measurement in an overall measure of health-related quality of life. And in this case, a different intervention emerges as the one that maximized the outcome. That was the full treatment package that also included the support groups. If you cared instead primarily about an improvement in engagement with medical care, which was in the lower left panel, a completely different set of interventions emerges as being on the frontier. And indeed, many of the potential intervention combinations were either dominated or extended dominated by a combination of in this case, this was PM, the peer mentoring. When you combined viral load suppression, quality of life, and engagement in care with weights determined based, in this case, on an elicitation exercise conducted with the investigators that argued that the improvement in viral load was about twice as important as the improvement in value and quality of life. And each together in combined were roughly 9 times together more important than the improvement in engagement with care. That when we set a composite value function representing all three, the full value efficiency frontier included the short navigation, long navigation alone, the motivational interviewing together with the long version of navigation, motivational interviewing with the long navigation, but adding in peer mentoring, and then finally the most effective overall in achieving combined value was the full treatment package effect. But it did so with a relatively large improvement or a large increase in costs. And the question then becomes, is it worth it to pay that additional treatment cost to achieve what seems like a relatively modest improvement in overall value? And therefore, what would be the intervention or interventions that would be assigned in a confirmatory evaluation RCT? So let's put DAIVE in a little bit more context. So I want to give a little bit of a history lesson here. So how is DAIVE different from other evaluation approaches? Well, in the beginning, and I'm going to show you this is way back in the beginning, there was cost-benefit analysis. And for those of you who've taken economics or public policy evaluation, this is still a major way of evaluating public policy proposals in a wide variety of areas. Less so in health technology for reasons that we will discuss, but is still a primary way that public policy is evaluated in a large number of areas. The idea behind cost-benefit analysis is to choose the best option available when we have constrained resources. And this has been the goal of economic evaluation since the beginning of the science. So when I said way back, I meant Sir William Petty, who is a fellow of the Royal Academy of Sciences in England in the 1600s, conducted what is thought to be the earliest formal cost-benefit analysis. And interestingly enough, it was related to medical care. William Petty was also the first, probably scientific advocate for universal health care. And the way he did it was he looked at all of the work product value of all the workers in England and made an estimate of how much they contributed to the overall product of the empire. And then argued that the cost of medical care and medical care that could prevent loss of life was effective enough that the value of human capital was greater than the overall expenditures expected to be spent to save that value. And he called it human capital, a term that was sort of reincarnated by Gary Becker, and for which he won a Nobel Prize from his work in the 1970s on human capital theory. And therefore, because the benefits exceeded the costs, that the state should provide medical care for all. Ever since then, health economists and all economists, clinicians, ethicists, policymakers have tried to make similar calculations about health-related policies, but there's this sticking point in that we don't want to necessarily judge the value of human life only on the basis of its work product or human capital. And just the very idea of assigning a value to life in dollar terms, pound sterling, or what have you, is problematic and has caused a number of struggles. So how cost-benefit analysis works more formally is to create a decision rule. And I'll try to explain this math. Don't let it scare you yet. I'll try to explain what's in each of these pieces. If I were to read this in English, what I would say is to do the policy if and only if the sum of its costs is less than the sum of its benefits expressed in dollar terms, or that the difference in dollar-weighted value of benefits minus the costs is greater than or equal to 0. So delta C is what we call the incremental cost of an intervention, and it's measured in money. It's how much additional does it cost to deliver the intervention relative to doing the status quo. Each of the delta EJs is an incremental effect of the intervention. And it's usually measured in natural units. In different policy domains, it might be per ton of carbon dioxide emission reduced. It might be per traffic fatality averted. Or in the case of behavioral interventions, it might be per successful tobacco cessation at 6 months. It can be measured in drinks per day, deaths from overdose, or in some composite scale of interest like the Addiction Severity Index, or the PROMIS Fatigue Short Form, or the Hamilton Depression Rating Scale. Could be any outcome of interest, or more than one outcome, right? Because cost-benefit analysis allows there to be multiple outcomes, which is a feature that we find very desirable. However, this comes at a cost. Because those outcomes are measured in natural units, which are very interpretable, very intuitive, but we need to put them on a dollar scale, we have to come up with a set of lambdas. And the lambdas are where the economists and policymakers and ethicists struggle, because they require what are called shadow prices or willingness to pay. And that's measured in money per unit of improvement in outcome. How much is the decision maker willing to pay to achieve an additional tobacco quit, or a 1 drink per day reduction in alcohol consumption, or a death from an overdose? Those are obviously very different concepts that would require very different shadow prices. Some are going to be more problematic to come up with weights for than others. Well, cost-benefit analysis then takes those delta EJs, those changes in effectiveness, and it converts it into a monetary value. And so it can be compared on the same scale as the incremental costs delta C. There's more than one intervention under consideration, as is certainly going to be the case with multi-component intervention optimization. We can compare them all to the status quo individually and then choose the one that maximizes net benefit as the preferred option. And you can, in fact, you can rank order potential options based on their net benefit. Cost-benefit analysis has been the predominant approach for economic evaluation in public policy in every sphere except health interventions. And that is largely because of clinicians' reluctance to put a dollar value on human life. Now, it turns out that when you make hard decisions about which interventions to use and not use, and how to use society's limited sets of resources to deliver interventions, this is an unescapable fact. We are always going to be forced to come up with these difficult value propositions. And not making a choice is still making a choice. If we simply adopt everything without consideration of the cost consequences and the opportunity costs, then we are potentially displacing other aspects of healthcare. We have to come up with those funds from somewhere. Somebody will pay that cost somehow, and we have to confront those difficult trade-offs. But in order to help avoid the direct need to come up with a willingness to pay to save a life, a lot of health technology assessment adopted the alternative and very closely related evaluative framework called cost effectiveness analysis that first became popular in the mid to late 1970s and has really dominated the field of health technology assessment since then. And a particular form of cost effectiveness analysis we will talk about next is the way that the majority of technology assessment is done around the world. However, in its sort of purer form, cost effectiveness analysis has a simple rule. It says pick the single outcome of most interest to you. Calculate the incremental cost. Calculate the incremental effectiveness of the intervention in that particular outcome of interest, and compare it to a single willingness to pay. And if the ratio of the incremental cost to the incremental effectiveness is less than the willingness to pay, then you do the intervention. And if it's not, then you stay with the status quo. This avoids having to explicitly convert health benefits to monetary units. So we don't take delta EJ and multiply it by lambda J. We take this ratio and compare it to lambda J. Now that may sound like it's very similar, and it's not escaping the hard truth. And in fact, that's generally the case. If there's more than one intervention under consideration, we conduct a cost effectiveness frontier analysis. And that word frontier is quoted because it should look familiar. The incremental cost effectiveness analysis frontier does something very similar to what we do with DAIVE, and in fact is an almost equivalent approach where we define things a little bit differently with DAIVE, but we borrow the same basic idea. Here, there's a single outcome, and we compare it to a particular slope, lambda J, the willingness to pay per improvement in single outcome delta EJ. And in this case, we find the point on the value efficiency frontier. I've only shown 6 interventions here. And in this case, intervention E would be the preferred or optimal intervention because it is on the frontier, so it's an efficient use of resources, and it is the most effective use of resources that produces an improvement in outcomes that is achieved with an increase in costs less than lambda J per improvement in cost. So thinking about this sequentially, starting from the minimal intervention A to C, we find that C improves outcomes at a cost, and the improvement in costs is less than the rate at which we are willing to exchange our dollars for an improvement in outcomes. And so C is preferred to A. We look again and compare now E to C and find again that E improves outcomes relative to intervention C, and again does so less than at the rate that we are willing to pay for those improved outcomes. And so E is preferred to C. But once we now compare F to E, the improvement in outcomes comes at too steep of a cost. It's more than we are willing to pay to achieve that improvement in outcomes. That slope of the incremental cost effectiveness ratio is greater than lambda J, and so we stop at E. And that's how we decide that in this case, E is the preferred approach. So cost effectiveness analysis was designed to avoid the discomfort of converting health effects to monetary units. We no longer take improvement in outcomes, multiply it by willingness to pay, and subtract it directly from costs. However, we don't fully escape the problem. Ultimately, comparing the incremental cost effectiveness ratio to lambda J still requires value judgments, particularly if our intervention outcome happens to be life or death. And so everything pivots on the lambda J's. What we decide to choose as optimized depends on that willingness to pay. Cost effectiveness analysis requires that we put effectiveness of all interventions to be measured on the same natural unit or scale. And if we are evaluating multiple interventions in the same disease area, the same overall goal, that's not necessarily a problem. But cost effectiveness analysis of the type that we have determined here does not work if you care about more than one outcome, or if you want to compare the cost effectiveness of interventions in various different conditions. So if I were an overall healthcare system manager and I wanted to prioritize my investment in my health system's resources, in interventions to deal with a variety of conditions, say weighing the value of an intervention to reduce smoking, to one designed to improve quality of life among cancer survivors, to one that's designed to prevent blindness in patients with macular degeneration. Those are 3 different interventions that involve completely different types of outcomes when measured on their natural units. How would I create a comparison that could capture and allow me to prioritize my resources across such various different types of interventions? Well, the answer was to try to come up with a single outcome that could rule them all. And that leads us to cost utility analysis. CUA is a form of cost effectiveness analysis. It's going to have a very similar look We do the intervention if its incremental cost effectiveness ratio is less than lambda, but in this case, the effectiveness is measured by a single common denominator that can be assessed for effectively all interventions. And the one that we use is the quality adjusted life year most often. The quality adjusted life year, or QALY, measures effectiveness of interventions on both the length of life, mortality, and health-related quality of life, or morbidity. So length and quality of life get put together in a single measure of quality adjusted life years. And therefore it can act as a common denominator for all kinds of interventions. Any intervention that either affects length of life or quality of life can be compared to one another using a QALY. Now, I think it's become increasingly clear, as we will discuss, that decision makers are becoming uncomfortable with the idea of putting all interventions into the same QALY framework, and that there are types of outcomes achievable and types of features of interventions that don't fit neatly within the measure of QALYs. In order to make this comparison, then, we have to have a value for lambda k. So what is our willingness to pay to improve an outcome by one QALY using an intervention? We refer to this as the health opportunity cost in the health technology assessment literature. And I estimated a value for this using in the US healthcare system based on the US healthcare system's productivity in producing QALYs. It turns out that it takes about $100,000 in the US healthcare system in general to increase health outcomes by one QALY by giving an individual health insurance. So giving them access to healthcare broadly by giving access to health insurance and increasing their healthcare utilization, it costs about $100,000 to increase health outcomes by one QALY. So any new intervention that produces QALYs at a rate lower than $100,000 per QALY can be expected to improve overall population health if you were to adopt it. But any intervention that would cost more than $100,000 to produce a QALY, according to this framework, would require reallocation of resources from elsewhere that might lead to more individuals being unable to afford healthcare. And as a result, they would lose QALYs at a rate faster than what they could gain them. And therefore, population health would decline. The problem with using QALYs, and I say problem here, not a problem that cannot be overcome, but it's a problem nonetheless, is that QALYs often require extensive modeling to take measures from within a clinical trial, whether it's an optimization trial or an evaluation trial or some other kind of trial, to map short-term measures of effectiveness into long-term impacts on mortality and health-related quality of life. And those models are not free. They take a lot of effort and time to develop, and often are very unstable because they rely on precise estimates of quantities that are difficult to measure in the real world. And once you forecast those short-term outcomes into the future, they can become quite uncertain. Another problem is that QALYs are not really utilities in the health economic sense, and they are only do so under very strong assumptions that are likely not true about society's preferences for experiencing different states of health for different lengths of time. Perhaps more practically, QALYs have become very much a focal point in debate over policies to control healthcare costs using cost effectiveness analysis. And in fact, the use of QALYs has been banned under the Affordable Care Act and the Inflation Reduction Act for use by government in pricing and coverage decisions, including in drug price negotiation. They cannot be used directly. They can help inform, but they cannot be used as a threshold to determine whether a treatment should be covered or not covered, for example, by Medicare or Medicaid, or how much Medicare should pay for a drug on the basis of its cost per QALY. Well, cost utility analysis was really designed to do something that we may not actually need in the intervention optimization phase of most. And that it was designed to expand the scope of cost effectiveness analysis beyond clinical decision-making to prioritizing healthcare interventions across the entire healthcare system and determine access to that. As such, it required that single common denominator measure of effectiveness, and so that's why we use the QALY. Economists largely recognize that QALYs are really not utilities, and therefore that cost utility analysis is just a form of cost effectiveness analysis with QALYs as the common measure of effectiveness. The pushback against the QALY has come together with recognition that there are many other important technical, ethical, and social considerations beyond length and quality of life impacts of interventions, including things like equity that you've probably heard Jillian talking about, or other factors that determine optimality of an intervention. For example, the Institute for Clinical and Economic Review, with the intentional acronym ICER, their 2023 value assessment framework includes these other features other than QALYs explicitly in their framework, as does the so-called value flower based on multi-criteria decision analysis that has been discussed a lot at ISPOR. And that value flower includes a number of elements of an intervention that go on to determine its value. That includes things beyond QALYs and costs, including impacts on the family of the intervention, the value of having information about effectiveness, or the scientific knowledge generated by studying an intervention, dealing with diseases that are particularly severe, providing hope to patients, whether the intervention improves or has a harmful effect on equity, and other considerations. So we've got cost-benefit analysis, cost-effectiveness analysis, cost-utility analysis, multi-criteria decision analysis. Oh my gosh, what do we do? Right? Why are we proposing yet one more acronym? Is it an acronym? Yeah, it is. DAIVE's an acronym, right? And there's always one of my postulates. I'm sure this is not a unique postulate to me, but there's an XKCD cartoon for any scientific talk. And in this particular one, we have two people who are trying to make a very specific decision, a purpose decision. Which car do we use? If we steal one of those cars, we can get to the base and defuse the bomb. Talk about a goal, right? One on the left accelerates faster, but has a lower top speed. The right one has good traction control. Other roads wet. And if you ever need to defeat me, just give me two very similar options and unlimited internet access. In this case, we want to make sure that the way that we make decisions is consistent with the objective of the decision. And so why DAIVE? Why do we want to do this particular approach? Well, it's important to recognize, and I'm here at my last two slides, so I'm about to wind up and ask for questions. So what does DAIVE do and what doesn't it do? DAIVE does consider multiple decision relevant outcomes in natural units. Right? So we talked about viral load, we talked about quality of life, we talked about engagement in care. These are units or scales that are familiar to intervention scientists, clinicians, patients, and other stakeholders. It does weigh the decision maker's value of multiple outcomes against one another in lieu of converting to QALYs, and so avoids some of the concerns involving QALYs. It can include other technical, ethical, and social considerations, such as the value of knowledge, scalability, and equitability of interventions. It does not require extrapolation of optimization trial outcomes to long-term costs and QALYs using often complex and costly to develop simulation models that can often compound and magnify uncertainties that exist at the optimization phase. And it doesn't say whether society or the healthcare system should reallocate resources away from other programs to pay for the optimized intervention under consideration. That's a drawback. But yet, at the optimization phase of most, that's not really what we're trying to do. In the optimization phase of most, the goal is not really to prioritize multi-component interventions against all other possible uses of resources for all other conditions across the entire healthcare system. Its goal is to advance a subset of multi-component interventions that have the most promise of delivering valuable outcomes under different levels of resource constraints to be further studied in an evaluation RCT. And so when talking about making a decision fit for purpose, we think that DAIVE is a useful tool to be considered as an alternative to more traditional cost-effectiveness analysis at that stage. Now, cost-effectiveness analysis still has an important role in evaluation of interventions, but is probably more appropriate after the evaluation phase, after a greater picture and a more resolved picture of the overall intervention effectiveness can be considered with additional research. And so I'll thank you and welcome questions and comments and thoughts.
Wonderful. Thank you so much. So interesting, though I guess I'm a little bit of a biased party to say that. But yes, we have a few minutes for questions, comments. You can put them in the chat or feel free to raise your hand or just unmute if you have a question for Dr. Vanness.
Maybe as we wait for questions to come in, Dave and Jillian, one thing you could maybe just think through is like, what are some of the challenges of people who want to use or are seeking to use DAIVE, or what are some common things that you've seen come up?
Yeah, that's a great question. I'll throw out one, and Dave, of course, you can react to that one or add others. One of the challenges that I've seen is deciding what cost should go on the y-axis of the various plots that you've mentioned. It could be delivery cost, like was mentioned. It could be a cost that's quantified in terms of time. It could be another relevant cost. And I think picking what's best for that balancing is a challenge.
I would agree. Cost measurement is always challenging, right? And I think for anybody who's done a study and has engaged with health economists to help in those regards, it can be quite challenging. Sometimes things are easy to identify. You need to put in the specific time of a skilled provider to provide a part of an intervention component, or the component is something like a nicotine patch that you can put a price on. Other times, the price might be complexity, right? And the complexity of the intervention. I think the question is, some of those things are properly more thought of as outcomes and can be brought into the value function somehow. Mm-hmm. But the other consideration is what to do about long-term cost implications of these interventions. We focus in DAIVE on just the cost of delivering the intervention itself, but there are long-term costs that might be incurred. And in the case of successful interventions will potentially save costs in the future. We leave that more towards the more formal cost effectiveness analysis that would be done, say, after the evaluation phase, when a full model of the long-term effects of the intervention and the more broad societal effects can be identified. Oftentimes, the budget in an optimization phase study just does not allow for that kind of speculation.
Yeah, that's a great point. Can you maybe comment on finding a health economist to work with in some of this sort of work in the optimization phase, and finding a health economist who has an understanding of DAIVE, or just a general commentary on finding health economists to work through some of these questions?
Yeah, there are supply and demand issues, I think, with health economists that many of us are pretty fully engaged in work. I am always interested in hearing from investigators who are using most and are interested in this work. I see Jen Cantrell is on the meeting here. I have the pleasure of working with Jen on one of her studies. We're at a very early stage, so only have really started conceptualizing how we're going to use these approaches in her study. Hi, Jen. But I certainly, feel free to get in touch with me. There are many other investigators who use cost effectiveness analysis for intervention science. And at NYU, you're very fortunate to have Heather Gold, who is, I think, one of the best health economists out there, who does work in this area and is an expert in intervention science. I think I want to try to, talk more about most out in my world as well. And this morning I had a nice. This is my second talk of the day. I gave a talk on a different, more technical talk today to some health economists and decision scientists. And I'm trying to introduce them to the most world and trying to get more people involved as well there.
Wonderful. Well, I guess we're at 2:00, so we'll wrap up, but thank you again for the super interesting talk, Dave, and thank you everyone for being here with us today.
Thank you. Feel free to reach out. And thank you for the invitation.
Yes,
Thanks, Dave.
absolutely.